look at it from the other way around. I have been trying to make observations because as a referral center in Bombay, we get patients from all over the places. And when I look at, there will be a lot of referrals. If you look at the past treatment, I have seen relapses even in extended cases of treatment. That's what I said in the beginning, no regimen is free from relapse. We have seen relapses in your FDT 12, FDT 24, extended MDT given up to 6 years, 8 years. I've seen relapses in RO patients. RO has the highest, that's why ofloxacin was dropped. And then you have Rome relapses. So practically none of this dapsone monotherapy, that is well known.
Then if the smear is more than 4+ or 3+, don't you think that when we stop the treatment, why don't we send a tissue for resistance of drugs? Is it, it is not feasible. I'm just asking whether we can send a tissue.
You mean to send the
because
tissue?
When Nandakishore spoke about relapse, he said 3 patients he has sent the tissue. And all the 3 patients they have found rifampicin resistance. That means when we stop the treatment itself, they might have been rifampicin resistant. Therefore, then they relapsed. So, if we could send a tissue at the stopping of, no, I'm just putting ideas.
Yeah, no, that could be a part of the research investigation. That is what this study was being done.
Yes.
To look at those areas where patients come back with fresh lesions, new lesions, extension of old lesions. Suddenly the patient says there's a new crop of lesion, or lesions have been extending. How do you sort of investigate this patient? So whether are we dealing with query resistance? So in such research investigation, this was a ICMR study, and that has been being under publication now.
Yeah. Now we will, Madam, I'm calling on you. Dr. R.G. Cochrane, the famous leprosy pathologist, said that the Schwann cell is the ideal haven for Mycobacterium leprae. You have corrected me also. Please comment on this.
Yeah, it's a true statement. I don't think we have any doubt now, because we have good evidence.
Don't we require a further study on the Schwann cell? Because we know the Schwann cell and all that. I read also C fiber Schwann cell.
Yeah.
Now that is the first time I am coming across that. C fiber Schwann cell. Of course, Schwann Schwann cell covers the fiber, but C fiber Schwann cell, first time I saw in your comment. Please tell us about this.
Well, C fiber are the non-myelinated fibers, they are called, who are also dealing with the somatosensory component of the nervous system.
Yeah.
They are the main targets for M. leprae multiplication. That has been well established now, even in human studies. And then tissue culture, of course, these are mainly dissociated Schwann cell cultures or organized culture. There is a specific affinity between M. leprae and Schwann cell that has been fairly well established. There's no doubt. So another sort of probably, it's not in the sense, it's not proved in that sense. But in the dermal level, Schwann cells normally are free-lying, are not associated with the fibers. There will be few free Schwann cells, which has a better capacity to engulf, or bacterial adherence to these particular fibers can just lead to their further propagation and multiplication. Once within the Schwann cell, it's actually understandable as to why they remain protected. Because as I mentioned in the morning, there is no enzymes that can tackle the bacteria or kill the bacteria. And another one of the proposed mechanism of how bacteria finds an entry into the Schwann cell, how do they get into the Schwann cell, which is not a phagocytic cell, because phagocytic cells normally engulf the bacteria. Here the question of getting engulfed by the Schwann cell doesn't arise, because Schwann cell is not a phagocytic cell. So there must be, so that is how the investigations were carried out, as to see is there a binding marker on the membrane of the Schwann cell. That is why one of the studies, famous studies by Rambukana and group, it says dystoglycan that is there on the membrane of the basal lamina of the Schwann cell is the adhering point. Bacteria adheres, then they get internalized, and then they get into the Schwann cell. Once they're within the Schwann cell, there is no enzyme to kill the bacteria, so they proliferate and remain protected. So this is the mechanism that is being, I think it's very easy to perceive this. It's quite possible that can be happening, though it is not demonstrated in the human system, mind you. because it's very difficult to do such experiments or, have, so whether, just connect all these things in the human system. Because when a patient comes to you, you don't know at what stage of infection he is, how long the bacteria has been lying, where it is. There are many other cells in the dermal, like dendritic cell, could be also one of the receiving cells as far as the bacteria is concerned, from dendritic to Schwann cell. So how does it get transferred in the human? If it can be studied little slightly better in a human system with an experimental, you can't think of injecting a patient and then following up with the process of evolution. How does it happen? Where do the bacteria go? Unless you have. I hope certain nanotechnologies that are being developed now may have some answer to address this question. Because main thing that we need to understand, of course, experimental model or the in vitro model is one. It's very difficult to directly extrapolate those findings to human system. So human system, we are just trying to construct what might be happening with early lesion, little late lesions and advanced lesions. So you put them and try to construct, like a process. So this is the way it has been, we have been trying to understand. So, but one thing is sure, Schwann cell is an ideal host, that has been well established. And Schwann cell, bacteria remain protected within the Schwann cell, that has also been well established. And even despite of the treatment, the persistence, the problem of persistence is also higher in the peripheral Schwann cells. That is also well established. From that point of view, we have no doubt. So, but then, if the persistent bacteria remain within the Schwann cell, is there any other way we can tackle it? Is there, like any other drug designing can be done to tackle the persistent bacteria? Because then persistent means they just probably switch off all their metabolic activity. That's what it means. They remain dormant. So what is this dormancy that is there within the Schwann cell that may be of good, like a value in addressing the treatment aspect of it? That is it.
Dr. Latish, before you think that you are belonging to the outside circle, you are very much in our mind. Can you tell us something about advanced flap rotation graft for plantar ulcers? One paper we published from Venlock Hospital, 30 patients. It is a simple ulcer. We don't treat complicated. Complicated, you have to help us. Simple ulcers, we did that in-step skin. We did an advanced flap rotation. Now, can you tell us something about this advanced? And second thing is, can sensation be gained by a flap rotation? You said arterial flap rotation. Nerve included in the flap rotation. Can we transplant and get a sensation? Because you said in one of the pictures, the patient feels that he is still touching. So can you enlighten us on this?
I have not read the article which you have presented, sir. Yeah. Regarding, if you ask me, if there is an ulcer in the weight-bearing area, what we look at it is the way any patient comes to me, and I look at it like a house which is a dilapidated house which is about to fall. So I see what is the problem now, basically whether it is a problem with the walls of the house. So ulcer is like a wall which is just given way, no? So just putting something on that may not give the long-term results.
Correct.
That's why most of the people say that we have treated with the ulcer with a graft or a flap, it just fails off. So if it is a problem with the pillar that we call as tendons, you have to correct that tendon problem first. And if it is a problem with the basic construct, the bone, then you have to correct the bone problem first. So it is all about treating a wound. A wound you can treat it with graft, flap, or any sort of thing.
Correct.
But it is how we have tackled the basic problem. So anything should work. So insect area is relatively a non-weight bearing area. So whenever we have an ulcer in the foot, we see whether it is coming in the weight bearing zone, and we see whether the non-weight bearing zone is good. If the non-weight bearing zone is good, just like hand, the foot also has got good vascularity. But if you see the vascularity, the epidermis is very thick. It is the dermal area which is good vascularity. So when you put a flap, you have to always tell the patient that your outer epidermis is going to go, because the patient will think that your flap is gone. But it takes nearly about 2 months for you to say that your flap has survived.
Yes.
And you have to make him walk, and we say a flap has survived and we are successful in treating if the patient is relatively ulcer free for a period of 6 months. So all the cases which you have shown has gone beyond 6 months to 1 year. So I think the way you have done an in-step flap, definitely, because we have an arterial circle. Any random flap where you take is based on an arterial circle. And if you have a good artery and a good vein taking it back, definitely it will survive.
It will survive.
Then
So
second
now-
part is about sensation.
Yeah.
Whatever sensation he is having, if you take it and then turn it, they say that for a finger, if you turn a flap, they'd get 80% of the sensation which was there previously.
Good.
So whatever sensation is there, 80% you will get.
Yeah. Thank you very much. It's a wonderful answer, and now we know the difference between ulcer and wound. You see, the ulcer in leprosy is something different than simple wound. Many of them are very infected. How you have to take the infected tissue and for graft protection. Can you tell us something more about preventive methods? Like, for example, if a patient comes with anesthesia, that's the time when we can mostly they'll come to skin department, etc. Can we tell about the preventive? Because what we thought Derek told also is that we should more go in the preventive aspect in society.
Yeah.
So preventive aspects of ulcer prevention is very important. I think you are the best person for us to enlighten. What are the preventive aspects would you advise?
Yeah, correct. No, any patients whom you treat the ulcer, if you see, rarely we get patients with ulcers on both feet, even though they have a leprosy in both sides. So that's what I was seeing. Most of the time they have only one feet. Then we examine the opposite feet. They have their threatening features to suggest that they're going to have a threatened ulcer there. And we tell them that you see you have a problem here which we can tackle even before it appears and it goes to that side. It is the fact of motivation which is most lacking in them. People are not really educated about it, and they are reluctant to get a feet which has been normal to get operated before it goes in for.
Correct.
They said no, 1 feet only, I am suffering so much, and you are trying to do something on the opposite side, it won't heal. So this wound healing is one which is always worried about. So if you look into the preventive aspect, we put all the patients to pedobariographic study. We take X-rays, see where is the pressure point. We try to offload with modified footwear. We have MCR footwears only here, but it has gone to next level. It has gone to the micro-cushion, polypropylene, lot of polymers which are softer, and you have to even assess their surface area, the pressure point, and then you give footwear which is based on their characteristics. So each sole has to be accustomed to the patient's weight, height, everything. But it's still a long way to go.
We used to tell the patient, unless you give 3 months for us, you should not, we cannot treat you. This is what we used to tell. We may be wrong also because you may have different.
No, I feel if the patient doesn't work, definitely ulcer will heal. So, but how long you can keep him
But
away?
when a person with ulcer, let's say 1 inch ulcer comes, what do you tell the patient? See, after your operation and how many days he has to stay, how many days he has not to walk.
Yeah.
How long duration do you advise for the patient to?
Normally, if I do a flap, 1 month the patient doesn't put foot down. So after that, most of the patients by 1 month they start walking. Even if you tell not to walk, they'll walk. So
That's it. Okay. Yeah. Madam, it has fallen in love with Schwann cell. I am too much aged to fall in love now. But Mycobacter leprae falls in love with Schwann cell. Now, why nerve tissue has not been tried in bacillary culture? Mycobacter leprae.
Yeah. You're asking why it is not. It is being tried in the nerve culture. It's
Enlighten us,
that's
madam.
correct to
Enlighten
say
us.
that it is not.
Yes.
Yes, it is being cultured. And mainly in the dissociated Schwann cell cultures and organized nerve cultures, they have tried to cultivate or grow bacteria. There is, at some extent, some tenfold growth has been established in the Schwann cell cultures. But the problem is, it is not found to be very productive in that sense, because to maintaining a culture is an expensive, technique. Tissue culture, maintenance of culture, and growing bacteria in the tissue culture. It's a limited growth.
Yeah.
It doesn't grow beyond tenfold. So that means there is a limitation, like mouse foot pad, it grows 100-fold, 10-fold, things like that. So it's not a very fruitful exercise in that sense. That's why people gave up doing that, because meanwhile we had the armadillo, which has come as a boon in terms of bacterial cultivation.
Correct.
So the full focus got shifted to armadillo
Yeah.
from the cultivation point of view. Otherwise, Schwann cell was tried. In fact, even nerve extracts were tried to see whether it enhances the growth. Pure nerve extract, explant cultures, monolayer cultures, all that were tried as cultivation for bacteria has been tried,
Yeah.
and it is successfully done to some extent.
Now another question, Mycobacter leprae and Mycobacter tuberculosis are like brother and sister. Both
Yeah.
are Mycobacter. Of course, there are many Mycobacter,
Yeah.
but these two are very much similar to each other, except that one is a generation time is quite long, another generation time is quite short.
Right.
Now, why Mycobacter tuberculosis can grow so easily and Mycobacter leprae resists?
One of the reasons that has been extensively quoted now by Thing is that Mycobacterium leprae has got 1,160 genes have been deleted from the M. leprae.
Oh.
There's a gene decay that has happened because of its long intracellular persistence. So it has become an intracellular dependent bacteria. Unlike M. tuberculosis is growing, it has got a large metabolic genome in that. So this is one of the reasons that is been shown, at least proved as a reason for non-cultivability as compared to
Cultivatable.
Yeah.
Now, there are certain cutaneous mycosis in dermatology, some one or two, which have been treated with heat therapy. Nandakishore, you may remember. Could we not try heat therapy for tuberculosis leprosy? Any one of you can take it. Ah, yeah, here is somebody occupying the dermatology is, yes.
At what temperature it will die?
No, that cutaneous mycosis, one of the cutaneous mycosis can be treated with heat therapy.
No, what temperature?
That's a very high temperature compared to our this one.
The
It's
tissue
an
will die.
electrically modified device. You can keep it on that and it can get big rest. Let's say chromoblastomycosis or one of the two, or blastomycosis. Now, can we use the same type of therapy for one localized leprosy patch? That was the question.
We can pass the question. Because the wounds in the foot.
You wanted to say something, please tell. No problem.
I got confused.
Now, if you can heal the wound with heat therapy, that will be a very welcome thing. Please.
No, wound in the foot doesn't contain Mycobacter leprae. So the question has to be answered.
Okay, right.
I think you will end up in burning that tubercular patch, that's all, because it has no temperature, you will end up burning that, he will have a burn injury there. I don't
No,
think
but one thing, do you mean to say that the heat therapy which has been suggested in Rook
Yeah,
can
no.
burn the mycosis patch?
No, but tuberculosis patch is an entirely different issue altogether. I don't think it will work out. And moreover, the heat therapy nowadays is more of a, historical importance, just like the heat therapy for syphilis, all those, they induce pyrogens
This
and all.
is a controlled heat, because when other venues of treatment fail,
And,
the heat therapy.
In tuberculosis, there is a bacillania. There is a small number which is there in the other tissues. It's not that the bacilli is only in the tuberculosis lesion. There is a bacteria elsewhere also which are not detectable. That's all. There is a small load of bacilli even in tuberculosis which are not detectable.
No, but one thing, there.
So I don't think
No,
it can
but
be.
then the question comes.
That's what I feel.
Now, in cutaneous mycosis, do you mean to say there are no mycosis? No, yeah, just it. Okay. Well, sir, you want to talk something?
Do you think it is a hypothetical question? Would you like to?
I think it's more of a, maybe your reasoning may be there, but then
It doesn't make sense.
doesn't, yes.
Okay, right. Anyone? See, he's telling phototherapy chamber because he wants to do some Manipal, he wants to invite patients. No, okay. Right. We take it at that. Now, one more question. When we send a indeterminate leprosy or tuberculosis leprosy for histopathology, madam, we see just a linear infiltrate. Comment. Now, can you tell us something more about this? When we see the slide, only we see linear infiltrate. We don't see other things. What other places would you like to focus our mind in histopathology in a indeterminate or tuberculosis leprosy?
Skin lesion.
Yeah, skin. Oh yeah, add nerve also. If you can tell us features, because some places you want to comment on nerve. What has happened? Please tell us, enlighten us about nerve effect.
Even nerve biopsies also.
Yeah, nerve biopsies.
Yeah. So the other features, in fact, just saying just infiltrate around the nerve is rather, inadequate. You can certainly comment on the nerve per se, in the sense the perineurium, that is an important pathology that reflects if there is perineurial peeling, for example, multilayering, or infiltration between the perineurial cells, that is indication of, on the lepromatous end of the spectrum. So it can give you more detail. And the nerve per se and the endoneurial structure, the integrity can be commented upon. If the infiltration is scattered within the nerve, that tells you what spectrum of leprosy that belongs to. And perivascular infiltration. All this should be looked into and commented upon, because each point, like for example, Schwann cell proliferation, if it is there, again it's an indication of, early leprosy. Schwann cell proliferation, fibroblast proliferation, increase in number, perineurial structure that can be commented upon, and the distribution of infiltrating cells, whether they are macrophages, lymphocytes, where they are positioned, extraneural, intraneural, perineural. All this, aspects should be looked into and reported upon, because that can reflect on type of classification. Yeah.
Nandakishore, you want to say something? Nothing. Yeah.
Yeah, AFP is another thing. Of course, you should very carefully look.
That's it. There has been a question here. A chronic ENL patient is unable to afford thalidomide. What do we do, Dr. Vivek?
Chronic ENL
Patient
affordable for not affording thalidomide. I think we at our center, whether it is affording or unaffording, we are providing free of thalidomide. We make provision for that, and then we are giving that. But maybe the situation at other places where thalidomide is not available, government is also not supplying.
Yeah.
So you'll have to make it as an institutional provision. And in such cases, I mentioned about clofazimine as an anti-inflammatory drug in high doses, of course, in divided doses. That can be given for a pretty long time, so at least to the extent of 6 to 8 months, starting with higher dose and tapering the probably